Hi, everybody. Thank you for joining us. This is Jeff Adest. I think many of you have heard me speak before. Today, I have the pleasure of being joined by Alicia Shickle, who is the president of Garfunkel Health Advisors. So for those of you who do not know, we started a healthcare consulting company about a month ago. And Alicia is the president of it and provides various documentation and coding services, which she will talk about later. The reason that we are having the presentation today, besides the fact that we haven't spoken to you in a while, is that there are three significant things which have happened over the last month or two that we wanted to talk about. One relates to an OIG opinion that came out dealing with giving out free gifts to patients. And that's something that I get questions about periodically. And so wanted to provide an overview and talk a little bit about some of the things you can be doing for that, which I know that gets people very nervous when we start talking about giving out things for free. But there are certain things that you can do in various circumstances. The second is to talk a little bit about COVID. Obviously, that's probably the primary focus of what most of you are dealing with. And I want to go over a few points of questions that we get regularly and that hopefully can provide you some guidance with it. And the third, and maybe the most important, what Alicia is going to talk about is that the entire process for doing CPT and E&M coding has changed effective January 1, which means that how your doctors are doing coding and how you're billing for it is significantly different than what it was. And while you might say to me, it doesn't really make a difference because for Medicare and Medicaid, we get the same amounts. It's not necessarily the case because first of all, you also have commercial patients, many of you, and second of all, even with regard to Medicare and Medicaid, you still could have problems if you're not documenting appropriately with regard to medical necessity and with regard to being able to have a valid claim. Which depending on the state you're in, right, if you don't have a claim that's accepted by the managed care company, you may not get your enhanced or wrap payment as well. So that's the third part that we will talk about. As always, so I don't need to get this question like 20 times, we will send out a recording of this session as well as the slides either tomorrow or Monday. So you don't need to sit there with your camera and start taking pictures of screens or send this question in many times. And I'll repeat it again in a couple of minutes if people get on late. We will be sending out the slides and the recording. Okay, so the first thing I want to talk about is about providing incentives and basically your fraud and abuse laws, right? So most people, the example I always give, like if we're hiring a new associate, right? It's a very basic example, but I think it applies very well. If you're a butcher and I'm a baker, and I say to you, okay, any people who come into your shop, you send to my shop, and any people come into my shop, I'll send to your shop, and this way the two of us could both make it and both do better. That's a great business deal. Right? In healthcare, it means you go straight to jail for that because you're basically saying is I'm going to make referrals to you in exchange for you making referrals to me. And in general in healthcare, the view always is we can't give anything to anybody for free. We can't pay anybody for referrals, anything like that. And that is the general rule, but there are some exceptions that we're going to talk about today. So there's a few different rules that apply, right? The main rule that people know about is the anti-kickback statute. Anti-kickback basically says that it's a crime to give or receive money as a way of inducing or rewarding referrals. So if you go to the local tow truck driver and say to him, anytime you go to an accident and someone gets hurt, tell them to come to my health center. In exchange for that, every patient you give me, I'm going to give you $25. That's a violation of the anti-kickback statute. Anti-kickback is basically paying someone for referrals. It's not dealing with you giving money to a patient, it's you giving money to somebody else to send a patient to you. This statute is very broad. Even if the service is needed, right? No one's saying the person didn't need to get the service, but the fact that they came to you as opposed to going to someplace else and you paid somebody for it, that could subject you to violating this rule. This rule has both criminal and civil penalties associated with it. It's, if you know about it, right, you have to know that you're doing it. You have to know you're paying someone for the referral, right? So it's either you have the actual knowledge or your reckless disregard, right? You basically don't care and you do it anyway. So nothing has changed with regard to anti-kickback, and that means giving anything. So where this often comes up is, for example, you'll have a pharmacy rep who will come in who will want you to start prescribing their drug, right? Pfizer has a new drug that comes out and they want you to start prescribing it. And so they'll go to your staff and say, right, we don't see this as much today. We used to see it years ago. We used to see, they'll go to them and say, okay, if you do this, I'll give you, tickets to a baseball game, or I'll give you a free trip someplace, or do things like that. So that generally would be considered to be remuneration, which would be considered to be a kickback in exchange for writing their prescription. So another example would be that you have a cardiologist, right? You don't provide cardiology services. You have a cardiologist in town and you refer your patients to that cardiologist, because they need cardiology services, and someone's actually willing to take your patients. That is fine. But if you say to the cardiologist, I'm only going to refer my patients to you if you agree that any patient that you have that needs primary care, you're going to send to me, then that would be a kickback. Now, again, I just want to be clear so I don't get a lot of questions. You sending to the cardiologist is fine. Cardiologist sending patients to you is also fine. Where the kickback comes into place is where you say, I'm only going to send patients to you if you agree to send patients to me. Now, I'm also going to say, so I don't get this question, right? We all know for referral tracking and things like that, you have the column 3 agreements. You have to have arrangements in place that say they will send the patient back to you so you can follow up on that patient. I'm not talking about that where it's your patient you're sending to them and they're sending back. But you're sending Charlie to them and you're saying to them, I'm going to send you all the Charlies and Marys I have, but you have to send me all the Sallys who are not my patients. That's where kickback would come into play. So like I said, there's very significant penalties that go with it, up to 10 years in jail. There are certain safe harbors. So you may come across this for those of you, which I hope is many of you, who receive grants from hospitals, right? Community benefit grants, right? So if you think about it, you make referrals to that hospital and the hospital is now giving you a community benefit grant, right? They're giving you money. So that would on its face violate the anti-kickback statute because they're giving you money and you are a referral source to them. There is something called a safe harbor, which is like a get out of jail free card, right? If you remember back to the Monopoly days, get out of jail free card that says for FQHCs, that basically says that even though you are a referral source to the hospital is allowed to give you a community benefit grant, assuming certain conditions are met. We're not going to sit today and go through all those conditions, but basically it has to be a written agreement and it can't be conditioned on you making referrals to them. And if you need more help with it, I'm very happy to do that. Please contact me separately and we'll go through it. Okay, next, there's something called the False Claims Act. So a False Claims Act is when you submit a claim to the federal government, which you know is false, or you know or should know is false. So the classic example, you read this all the time in the paper, right? People had, patients who died 3 years ago in a nursing home and they're still billing for that patient, right? That's a false claim because you didn't provide any services to that person. So, but another false claim, the way the federal government views it is if you saw a patient, you actually treated the patient, but you have no chart to show it, you have no record, you can't show medical necessity, you can't show any backup for it. It's just you did it, no one's claiming you didn't do it, but you can't show any backup. The federal government comes in to look at you, they could use the False Claims Act as a basis to go after you. There are significant penalties associated with this, right? There's a per claim penalty as well as triple damages that can go with it. Again, this is all for background. Now I want to get to the law that's most applicable to the conversation today, and that is applicable to the OIG opinion that came out a few weeks ago, which we sent out a notification about. So basically, the civil monetary penalties law says this deals with you giving things to a patient in order for the patient to come for the visit. So you say to Sally, you put an ad in the paper saying, hi, we're an FQHC. If you come to us, every patient who comes to us, we're going to give you a $50 gift certificate to Apple. right? That's you giving a remuneration, you're giving a benefit to a patient in order for the patient to come to you, right? These laws apply to Medicare and Medicaid. Some states may have similar laws. We're talking about the federal laws, right? So that's what if you're doing that, then you're running afoul of this law unless you meet an exception. So again, there's significant penalties that go with it. So there have been special advisory opinions. When the federal government issues a special advisory bulletin, that means they found that something is going on and they think there's a problem with it, and they're saying, hey, you know, out there, we know there's rules out there you don't pay attention to. Make sure you pay attention to this one. So they send something out about this, which says you have to be very careful by when you're giving away things. Now, they did say, as though, that you can give away things if they have a value of no more than $10 per shot or $50 in the aggregate, which in 2016, they now changed it to $15.75. So that means that if you're giving out pens that say your FQHC name on it, you don't need to worry about it. No one's going to come after you for giving out pens. There are still restrictions if you're giving out something that's cash value, right? So if you're giving out an item, a free mug, that's different than if you're giving out a gift card that you could use in a store. And we're going to talk about gift cards in a minute, but something small that you give out, you don't have to worry about. Now, there are two exceptions that are applicable to FQHCs. I'm not saying there are not others that would not also be, but there are two that are primarily what we're going to focus on today. Right, one is where you're doing something that promotes preventative care, and another one is where you're incentivizing people to get care that they otherwise need and would not be receiving. Okay, so talking about preventive care services, right? So much of what FQHCs do is preventive care services, right? So what they say is you can give some incentives for it, but things you cannot do generally is you generally cannot give something that's cash or can be converted into cash, or something that's completely outside the realm of the service you're providing. So for the examples they give that you are allowed to do. So if you want to tell, if you have a person who is pregnant, right, and I hear this as a problem all the time from FQHCs, right? The person is pregnant, and so a regular healthy person who visits a doctor would go for approximately 9 or 10 prenatal visits. And what most FQHCs end up happening is that many of your patients end up coming for someplace between 1 and 3 visits rather than the 9 or 10. So now Sally has come to you and you found out that she's pregnant. And now she is not coming back for a follow-up visit, right? She came to you in month 3 and now we're in month 7. You haven't seen her since then. You would be able to offer Sally something to make sure she comes for those prenatal visits. You also would be able to offer something that fits into the guide of preventive services, right? So if there's a guide, which I gave you a link to here in the slide, which talks about various things that the federal government is concerned about and wants to make sure people are getting. So obesity, STDs, drug alcohol abuse, depression, you know, the other things that are up here are things where that you fit into this exception, which again allows you to provide something to the person, with the caveat that again, we're not talking about giving them cash, and we're not talking about giving them like a gift card to someplace. We're talking about giving them something else in exchange for that. So a classic example that people give is like, you'll say to them, if you come for at least 6 prenatal visits, then when the baby is born, we're going to give you a baby basket, right? Which might include a bassinet and will include diapers and include things like that. So programs like that, they are permissible for you to be able to do. I'm not going to go through all the different scenarios because many different scenarios for that, but things like that are examples, right? So other things that you do, right, that fall into this category, right, are you do cholesterol screenings, you do things like that. When you give out things like that, you don't have that's not a problem to be able to do. Okay, if you do, gift certificates, T-shirts, things like that also can be okay for you to be able to do, right? Because those are not necessarily value. Now, gift certificates can be a problem, which I'm going to talk about in a minute. So let's just wait till we get to that. Okay, so there have been OIG opinions about this in the past, and those opinions have said things like giving out diapers, right? That's not a problem for you to do. If you're giving out other things for patients who have specific conditions, right? Hemophiliac patients, right? It's the idea is that if the service is ongoing, right? This is not what's getting the patient through the door in the first place. This is an existing patient who you're trying to get to come back for things that they need, then you might be able to give out certain gifts for it. So something that I hear a lot is adolescent visits, right? So you probably all struggle with this, right? It's one of the UDS measures, so that's why people talk about it a lot. As a general course, right, I think we all probably remember when we were teenagers, and I think that having 4 kids, 3 of them are teenagers right now, it's much more difficult to have teenagers to focus on their health care than it is other people, right? You get older and you don't feel well, you go to the doctor. When kids are young, you know you have to take them to the doctor. Adolescence is much more difficult. So you could, again, I'm not giving you a blanket rule, but in the right circumstances where you try to get the adolescents to come back and they're not coming back, you could have programs where you give them something in exchange for them coming back for their well visit. Again, that's not a blanket rule, so you would have to be a case-by-case scenario to be able to do it. Okay, so the other exception that I talked about is promoting care, right? So these are things that basically we want to improve their ability to get services, and it's generally not going to cause overutilization. So the example they give is like you're doing health screening, right? As you can see, as I'm talking about, these are a lot of things that FQHCs do, right? You're doing health screening, you're doing vaccines, you're doing education, right? Or you want to provide child care assistance, right? So the mother comes in and you have a daycare for her to leave her kid in while she's getting treatment. All of those things fit in this exception and are permissible. It's interesting to note that in the guidance, they specifically talked about FQHCs and sliding fee scales because they recognize we have to provide those, and says that is obviously okay to be able to do. Okay, so other things that you can do is giving things out for less than what it costs them, right? You're having a smoking cessation program and you want to give them a device to be able to measure, right? You're sending someone home with something to be able to measure the diabetes, right? Things like that you are allowed to give to them. Again, they get much more concerned when you give out gift cards, but there are scenarios where you can give out gift cards, especially if you're doing it in a raffle or it's tied to a specific condition, which I'm happy to talk about on a one-on-one basis. Okay. There are other exceptions, things like travel, which maybe we'll do a separate webinar on being able to pay for transportation, right? I know that right now, as part of HRSA Form 5A, you're required to provide some kind of transportation. I think most FQHCs provide, some kind of, tokens or cards that allow people to get on trains or things like that. You actually can provide transportation in certain circumstances. Like I say, that's not the focus of today. Maybe we'll talk about it in a different webinar. Okay, so there was an OIG opinion. By the way, now we have a lot more people on the word at the beginning. Again, the slides and the presentation will be sent out in the next couple of days to everyone who signed up for the webinar. So you don't have to sit here and be, taping it or listening to it. The presentation, including the recording, as well as the slides, will be sent out in the next couple of days. Okay. So there was an OIG advisory opinion. An OIG advisory opinion, what this is you have something you want to do, which you think should be okay, but doesn't fit squarely into any exception. So you go to the government and say, I want to do this program. What do you think? Now, the government says that I'm giving an opinion and it only applies to the people who specifically asked me the question. But as a general course, it's good evidence for us to be able to rely on to apply to other people. So in this case, what happened was an FQHC that came, and there are very few OIG opinions about FQHCs, but basically they found that about 30% of the pediatric patients missed some of their preventive care appointments. And so what they wanted to do is if they wanted to contact people who have missed more than two or more appointments in the last 6 months, and notify them that they could get a $20 gift card at one of 4 different stores if they've come and they've attended the appointment. And the gift card would be not dependent on what kind of insurance you have, and you can only get 1 gift card. Now, importantly, they said they would not advertise that they're giving out gift cards. It would only be calling the patients or emailing them or telling them, and it only was for pre-existing patients. So I just want to stop right here for a second. If the key piece here for why they needed the opinion was because in these appointments, they were doing things outside of direct patient care. But the OIG implicitly said that if it was only doing direct patient care in these visits, right? It's a classic pediatric visit, a classic adolescent visit, and it's people who have not come before, who are patients who have not showed up for the visits they were supposed to show up for. The OIG implicitly said that it would be permissible to give them the gift. The $20. It was permissible to give them a $20 gift card as long as it wasn't advertised. The OIG then went on to say that it was okay here. Again, the piece that they were focusing on was that there's other things being done during that visit other than regular patient care, and said that it's okay because even though it could lead to patients coming and it would be remuneration, they still said it's okay because basically the patients really need the care, and it would promote the delivery of preventive care, which is, like I said, one of the exceptions that exist. But something they looked at, again, is that it's only eligible patients. So these were patients who had not come who had missed at least 2 visits. I don't think 2 is a magic number. It just happens to be the number here. And it's unlikely to lead to overutilization, right? Because these are visits that people really needed and not visits that they were coming for that were completely unnecessary. It's not just about driving up your numbers. It's about making sure that patients get the care that they need. Okay, so they also looked at factors like that we have an internal policy, and we're going to go back and look to see if it's working, and that it's a one-time thing, and it's not like no patient you can't give it to them every single time they come for a visit. So that's the overall gist. Like I said, I think where this comes up is in many places, most likely prenatal care. It could be for having parents come and bring their kids to get various vaccines or get various shots they need, and could come up in adolescent visits. That does not mean it can't come up other places, right? If someone has diabetes who needs to come back regularly and they're not coming back and you want to do something to incentivize them, all those types of programs would generally fit within this exception, which, like I said, has to be analyzed on a case by case. So please don't go back and say that you listened to this webinar and I said it's okay for you to give out gifts, as many gifts as you want to any patient you want, as long as they're a pre-existing patient. Okay, next topic we want to talk about is FQHCs and the vaccine. But before I get to the vaccine, there's one other thing which I did not have in the slides that I just wanted to mention, because we've been getting a lot of questions about this also, which is dealing with provider relief funds, right? So hopefully all of you have gotten round 1, round 2, round 3 provider relief funds, and there's been a lot of discussion as to what those funds can be used for, what the PPP fund can be used for, what the HRSA grant fund can be used for. I'm not going through all of that now. I just wanted to make you aware that with regard to the provider relief funds, something that came out recently was that it can be used, well, it's not recent, but what they've said is it can be used to replace the lost revenue. They have now changed the definition of what lost revenue is. Previously, lost revenue meant that in 2019, we made $5 million. In 2020, we made $4 million, so I could use $1 million of the provider relief funds to cover that deficit. They have now said that you can use budgeted versus actual. So if you had a budget, right? So this should apply to any FQHC that uses at least a calendar year as their fiscal year. If you use a different year, it might be a problem. But basically, if you had a budget that was in place before the end of March and you did not hit your budget, right, which most FQHCs this year in 2020 did not hit their budget. You might not have had significant losses from 19 to 20, depending on where you are and what the impact on COVID was on you. But if you have, besides having losses year to year, if you have losses from budgeted to actual, you can use the provider relief dollars for those purposes. Also, as of now, they've extended, if you didn't use it all up in 2020, they've extended it to June 30th, 2021. Do I think they might extend it further? I think there's a possibility, but as of now, you can use the money through June 30th of this year. Okay, vaccine. So I know you're all dealing with vaccine every day, and you probably listen to a lot of webinars. There's just a few points I wanted to go over with regards to the vaccines. So in many states, FQHCs are the primary distributors of vaccines, and we get calls every day, and I will tell you that these are some of the hardest calls to deal with, because I think in many states, and the CDC has picked categories of people who are entitled to the vaccine that don't necessarily make sense to the person in the street, or frankly to anybody outside of them, in setting these categories. So I'm just going to give you an example. I was at an FQHC last week, and standing online to get the vaccines were, I don't know, approximately 15 people who were over age 75, most of them in wheelchairs or, with other walkers, things like that, who, if they catch COVID, most likely will be at great risk of dying. And standing in the middle of the line was a 20-year-old girl who happens to be a teacher in a school. Now, for those of you who might have, spouses or relatives who are teachers, I'm not picking on teachers, I'm just using it as an example. But the guy is the person who's a teacher, the person who works in the grocery store, I understand they have exposure to a lot of people. I don't really understand why they should go ahead of a, 74-year-old who most likely will die if they get it, and when the 20-year-old most likely will not. But those are the rules. As I'm sure you've seen in many states, there have been very public actions about, if you don't follow the rules, we're going to fine you. As an example, New York has imposed very significant fines for failure to follow the rules. So what I would tell you is you need to follow the rules. However, I'm not telling this as legal advice, right? I've gotten many questions from people at the end of the day. We broke open a pack and we have 3 left now. Are we really supposed to throw it in the garbage? And I guess my advice to you would be, let's use common sense. Are we going to let 3 more people die because the state said that they didn't meet the criteria, or can we find some other way to be able to use it? And I'll leave it at that. Okay. Something that is important that we keep getting questions about is consent. So there is nothing, vaccines are not any different than anything else in terms of consent. Whatever you're doing for other things that you give now, you should continue doing for these as well. Nothing different here, except you have to ask them a few questions that go with it. Okay, you need to make sure, obviously, that you're storing it and keeping it appropriately, because, right, we all know there's a shortage of vaccines, and if your vaccines go bad and now someone can't get it because you went bad, that puts I'll say a moral obligation on you beyond the legal obligation. Okay, in many states, the people that can give the vaccines are not limited to your classical healthcare providers, right? In many states, there are pretty much anyone who you give a little bit of training to can give the vaccines. So, but you need to just keep in mind, and I say this hesitantly, but HRSA has not followed along necessarily with what's going on with the vaccines, in terms of, technically, if you're engaging someone to give vaccines, that person is now involved in patient care, and technically need to go through a credentialing process for those patients. I will leave it at that, but according to the HRSA rules, you would need to. I understand it's very difficult, and I'm willing to have conversations with people offline as to how to deal with that. Okay, now another thing that's come up very often is how does it work in terms of being able to bill for a visit, right? So if you give the vaccine, there was a fee you could bill for the administration of the vaccine, which is like $13 or something like that. Many FQHCs are doing visits besides that. So my question to you is you need to make sure you're actually doing a visit. You can't just have the doctor ask those same 5 questions and then put in for a visit. There has to be something done at that visit independent of just asking the 5 questions that are associated with the vaccine. Now, I do think it's appropriate in many cases, especially when you have people who have chronic conditions or other conditions that could be impacted by it, to be asking questions and doing a visit. So there is a basis to be able to do it. You need to make a determination for yourself as to whether you're going to do it, because if you're doing a visit, then it needs to be a billable provider. You can't use the nurse or the EMT to do that visit, because they do not qualify as a billable provider. Another thing that I've gotten, and I don't have a solution for, hopefully HRSA will come out with something before it, is people keep saying to me, yes, I want to help people and I'm going to help people, but I understand that when I come to UDS at year end, these are now patients who are not otherwise my patients, and now when I have to do the reporting, my percentages are going to be wildly off, because I'm not going to have all the things I need to have for them. The adolescent well visits, I'm not going to have some of the other things that are normally necessary for UDS. And I guess my answer to that is, for today, I think you should be going ahead and giving the vaccine. That's a lot more important than the UDS. Number one. Number two is that hopefully HRSA will issue something before year end so you can exclude those patients from it. As a general course, there is FTCA coverage for this. There is a blanket rule that was issued by HRSA providing for FTCA coverage for COVID-related items. You still need to follow the rules as it relates to if you're adding a new site or doing it off-site or having the providers work for you, as well as if they're volunteers versus being paid, because the volunteers, there may not be coverage for them. That's what I wanted, just some of the small items I wanted to talk about. COVID, obviously if you have questions, we could follow up and we could do a separate webinar. Just as an overall thought, I think I mentioned this in the past, if you have ideas of things you want me to cover during a webinar, please send an email or post it in the questions now, and we will talk about those topics. Okay, at this point, I'm going to turn it over to Alicia. Just before I do, I'm just going to mention, like I said, we have added a healthcare consulting department. The reason we did that is that many of our clients need healthcare consulting services, and they get sent out and very often are not happy with the quality of services. So this way, it's a way for us to be able to work together with the people and ensure quality of services and ensure that legal is working together with the reviewers so that you get a complete answer which deals with your issues.
Great, perfect. Thank you so much. Yeah, and just to reiterate that Garfunkel Health Advisors is eventually going to be offering a whole suite of advisory services, including IT. I am actually president and overseeing the documentation and coding audit division. So it's really exciting, and thank you so much, Jeff, for including me today to be able to bring this really exciting information. Just a little bit about myself. I've been in healthcare 36 years. I've been doing a lot of advisory work. I do a lot of education, documentation, coding, training. Unfortunately, I do a lot of provider defense work involved with overpayment recoveries and audits. So hopefully the information we're going to bring today, hopefully all of you have already heard about this and it's old news. But we just want to make sure, because we're still getting a lot of questions from providers, and we still have a lot of providers out there who are not really feeling 100% confident with the changes. So, okay, let's see. So also we're going to talk about principal care management services, new opportunity for FQHCs in year 2021. So these changes to the office and outpatient evaluation and management services went into effect January 1st of this year. We know it's been eons and eons since we have seen a change to E&M services, but it has been much needed. So this is a very welcome change. We know the old guidelines are very antiquated, very complex. halfway into our training sessions, we see providers, heads, eyes would roll back in your head just because it was so inundating and very cumbersome, I think, in your day-to-day workflow. There were very significant error rates. And I know, as Jeff mentioned in the beginning, it's not always a big priority in your types of organizations to make sure that you're getting your CPT coding correctly in your ICD-9 coding, but it's really critical. The overall update to the program, the goal was really to reduce the administrative burden, take some of the documentation burden off of the providers, to improve payment accuracy. And I know a lot of times you're feeling that doesn't really apply to you, but there are so many other components of it that do apply to you. The accurate coding helps to support your qualified visit, and we're going to look at what those are and how this is impacting that. Also, probably you don't see many times that you're coming under audit scrutiny, but clearly FQHCs are not exempt from that, right? You could be getting inquiries from payers. These changes also impact commercial plans. Initially, we had a lot of questions around, CMS came out with a big announcement, hey, the new guideline changes. But CMS and AMA, the American Medical Association, came together. CMS actually adopted the AMA's required changes here. So these changes and guidelines are actually published in your new CPT manuals. All plans that, all people that bill for plans that accept these codes, so this is applicable to all commercial plans. Okay, so let's look at this. So, of course, these are not all of the HCPCS codes that fall under your revenue codes, but this is your new patient code that you utilize for billing. Again, these are face-to-face encounters with your patients for new patients. A new patient is someone who has not been seen in your organization in any of your sites by your providers in the last 3 years. Again, these changes apply to office and outpatient visits. So that's your 99202 through your 99215 codes. Any of the other codes or E&M services that you're still offering, like a nursing home visits, any of those codes are still going to be leveled by the 95 and 97 guidelines. And we are hoping to see some future changes there as well. But for right now, these are only going to be the only codes impacted. And then these are the codes that are impacted by the change that fall under your established patient revenue codes. 99212 through 99215. So most of all, and as Jeff was mentioning earlier, medical necessity is the driving force behind every visit. And when he was talking about, are you going to have a visit when you're giving your COVID vaccines? I think this is what you were really talking about. It has to be medically necessary over and above just coming in for the shot. So this is a great segue. It's always been the driving factor, and the documentation should really be accurate and complete to support everything that you are doing during that visit for the patients. How do you communicate your medical necessity or your levels of medical decision-making to the plans when you're submitting your claims? That is all driven through your diagnosis coding. So really important to make sure that you're comfortable also in the levels, documenting and coding to your highest level of specificity when it comes to your ICD codes. Documentation, I can't talk enough about this. I'm always up on my soapbox here because the work that we do with providers, everything really comes down to the documentation. Your documentation is, basically it's going to mitigate any question of unintended or dangerous patient outcomes. It's also going to mitigate any audits or possible overpayments. It supports the level of medical necessity. Right? It supports the level of medical decision-making that you are having these visits, you're billing for the services, the documentation is going to support that it was a qualified visit, and then the levels need to be selected accurately. You wouldn't select a 99215, your highest level E&M, and then put a diagnosis of allergic rhinitis or rash. It does not match up. And those are things that the health plans data mine for very frequently, specifically when they're looking at your E&M visits.
Right, just to jump in for a second, we have seen many FQHCs that have had audits, medical necessity audits. So this is not something that's just hypothetical. It's happened quite often, and we have seen, payers taking back significant money based on it. Because when they come in, what they do is a sample, right? And they'll pick like 10 claims, and if you have 3 of them that's a problem with, they now will say it's a 30% fail rate, and they apply that across all of your claims that are part of that year, and so it can end up being a lot of money. Yeah. I'll just throw in one other thing, which maybe Alicia was going to say anyway, but I'll just throw in that I've had people have conversations with me that say that for Medicare and Medicaid, it doesn't make a difference what level, so we'll pick a lower level, but for commercial, where it does make a difference, we'll pick a higher level, right? So obviously, if a doctor is seeing 2 patients in a row and doing the same thing for both of them, and billing a level 3 for one and a level 5 for the other, because the second one is a commercial patient, that's a real problem.
Exactly. And it doesn't, so a lot of times providers are not always 100% confident in picking the level. So they say, I'm going to pick it right across the middle. Sometimes I'm higher, sometimes I'm lower. But this is really about integrity, right? Coding, documentation coding, billing integrity, selecting the most appropriate code for the levels that you're billing for. And we see providers, I'm sure many of you have heard about the bell curve. And that's where the payers kind of look at the algorithm of what your coding is. If you're coding every visit at a high level, you are going to stand out as an outlier. If you're coding very low levels, then you're not coding accurately either. And then straight across the board, you're also going to show as an outlier. So that's really important to understand. Let's look at what some of the highlight the changes are. So 99201, that's your lowest level new patient E&M. That's going away because as we move into the new rules under the new guidelines, 99201 and 99202 both had a straightforward level medical decision making. So it's no longer really applicable. We had a lot of questions about this, specifically in your in FQHCs about 99211. Traditionally, that's been a nurse visit, and there is no provider involvement required. This code does not fall under the specified payment codes for FQHC under the prospective payment system. So when a provider is involved seeing a patient one-to-one, that's considered a billable visit. Really, the lowest level you should be selecting is a 99212. Again, so major changes, history and exam as key components of being counted towards a level of service is no longer applicable. Under the 95 and 97 guidelines, the 3 key components were always the history, the exam, the medical decision making. No longer do providers have to count up all the components of the history, which include your history of present illness, your review of systems, your past family social history, or the exam elements. And I know it's always like, well, if I'm going to bill a 99214, I have to have 8 organ systems or body areas documented. No, but the key here is that you still have to document a clinically appropriate exam for clinical reasons, for clinical purposes, for patient care, but you're no longer going to be counting those. The new guidelines say that providers can select their level of service either based on time, and we're going to talk about that. There are a lot of changes to the definition and criteria of time, and or medical decision making. So the good news here is that you actually have a choice. Sometimes in the encounter with the nature of the presenting problem, it's more beneficial or better to pick your level based on time, and sometimes it's better to pick it based on medical decision making. Okay, so under the old guidelines, time was only calculated on face-to-face time between the provider and the patient. And now under the new guidelines, you can count non-face-to-face time activities as well as face-to-face activities. I'm talking about provider time, not the time that your MA is rooming the patient or getting them ready or that they're at the front desk or they're in the waiting room. So it's only time the provider is spending working on that patient encounter on that day. So we're going to see some interesting. Back in the day, the provider's always like, oh, we spent all this time documenting, we never get credit for it. Well, as long as you are documenting on the same date of the encounter, you're going to be able to take credit for that now. Okay, it's really important Make sure that you're documenting. If you are going to be billing, selecting your level based on time, you have to document the actual time in the medical record to get credit for that, and then all of the activities that you performed. And we'll show you some great examples of what that looks like.
Right, but this is very helpful, I think, for some of you. We get complaints all the time about providers not closing their charts for a week, 2 weeks, a month, right? So like Alicia is saying, that they only get credit for time that's on the actual day of the encounter. If they don't do it that day, do it 3 days later, then they're doing it, so to speak, on their own time. They're not getting any credit for it towards the coding for that visit.
Exactly. So incentive, close those notes the same day. And with the reduction in all of the things that you have to worry about documenting now, it should be easy to get your notes done, go home, and not have to document on the EMR later at night or during the week. Even though in the past, evaluation management services have never been considered time-based codes, they've always had typical times attached to them. And there are new times that there's time ranges now that are for each one of the services. And this is what the times look like. Under the old guidelines, for example, a 99213 had a typical time of 15 minutes attached to that. But remember, that was 15 minutes of face-to-face time only. Now that the time has expanded to include all non-face-to-face and face-to-face activities, the time range has now expanded. So for 99213, the minimum time that you're going to spend with a patient is 20 minutes, up to 29 minutes. So here's the guidelines. And again, we're going to send out the slides so you can have all of this to refer back to. What is time?
This is just right. So Alicia, I think this is more minutes than it used to be, right? I understand there's more included in the minutes. Right, yeah. But typically a 15-minute visit before was a level 3, and now you're saying 15-minute visit is a level 2.
Exactly. So now it includes all of the time that you never calculated before. So it's important to be aware that these ranges have shifted dramatically. So yeah, back under the old guidelines, 15 minutes used to be in 99213. Now they put that range in because now you're including your documentation time if you're doing it on the same day. And here's a list of all things that you can include in your time: preparing to see the patient, if you're reviewing any old records, if you're getting a history, any counseling, education for the patient, the family, or the caregivers, ordering your medications and tests are all included in the time. Doing referrals, documenting clinical information in your EMR, again, as long as it's on the same day. And then if you're independently interpreting any results, care coordination, all of these things you can count, but you need to make sure that you're documenting in your medical record everything that you're spending time on. You can't just document, I spent 35 minutes with the patient today, and not have the backup behind it to back up the medical necessity for that visit.
Right, and just on that last point, I'm sorry, on the care coordination, right? So all FQHCs do care coordination. It only counts for this purpose if the provider is doing it. If someone else is doing it, right, that does not count towards the coding.
Yes, and also if it's not separately reportable. So if you're doing care coordination and you're billing for care coordination, then you cannot count that time towards your E&M visit. So that's important if it's not separately reportable. So when you're doing that and you're going to be billing it, calculating it towards your care coordination time, then you can't count it towards your E&M time. I think it's important, you know, I want to segue, this is a great segue into, so that's how you're going to bill your visits or select your levels based on time, but you also have the option to select your levels based on medical decision making. And the table, while the table hasn't changed very much, the elements within the medical decision-making subcomponents has extensive edits to it. So even under the 95 and 97 guidelines, the 3 components of medical decision-making were always the number and complexity of issues or problems that you're dealing with, how much data or the complexity of data that you're dealing with, reviewing, ordering, following, managing, and then the overall level of risk to the patient. So those 3 categories stay the same. However, the components within them have changed. Again, so here's the number. So under the new guidelines, the 3 components of medical decision making are the number and complexity of problems addressed, the amount and complexity of data reviewed and analyzed, and we're going to look at that because that category has really blown up. So there's significant changes to that. And then the risk of complications and or morbidity or mortality to the patient, and we'll talk about for briefly what that means. The categories under the data, so again, overall medical decision making, you're going to have the same 4 levels: straightforward, low, moderate, and high levels of medical decision making. And under the new guidelines, you only have to reach 2 of those 3 criteria here: either number and complexity of problems, data, and or risk of the patient. So you have to satisfy, meet, or exceed the level in 2 of those 3 components. But under the data is broken down in itself into 3 categories. So category 1, these are all things that you've already been doing, you're already documenting. It's just a new way of calculating them into your levels. So category 1 consists of your tests, anything you're ordering, documents that you're reviewing, orders that you're looking at the results for, review of external notes from each independent source or historian, and then also taking independent history. An independent historian, which would be someone other than the patient, like the mom or dad or parent or a spouse or a caregiver. And then category 2 is independent interpretation of tests not reported separately. So if you're independently interpreting some test results for something that you did not order or you did not bill for, then you can take credit for that. And then category 3 under the data section, and I'll show you how this kind of all fits together, discussion and management or interpretation of tests from an outside source or provider who's not part of your organization. Again, I know we don't have a lot of time today, but I want to make sure we go through this. So this is the grid. This shows you the 3 separate categories of the medical decision making. You have the levels here on the left-hand side. So for a level 3, 99213, the number and complexity of problems addressed. This is low-level medical decision making, 2 or more self-limited or minor problems, or 1 stable chronic illness, or an acute uncomplicated illness or injury. Those are all the number and complexity of problems that would fall under a low-level medical decision making. And then you can see here the data section, right? So it says you have to meet the requirements of at least 1 of the 2 categories that are listed in this grid. That would be, and any tests that you order are considered independent or could be considered 1. However, if they're things that you're ordering that you bill for in addition, then you cannot count them. So if you're ordering blood tests that you're not doing or billing for, like a CBC, a chemistry, a lipid profile, a hemoglobin A1C, you can take credit for 4 elements under that 1 category, and it's very easy to meet the criteria. And then the overall level of risk to the patient for these levels are low, considered low. And then the higher the level medical decision making, the more work involved, the more complex, the more ill the patients are. I just want to point out here, I'm sure a lot in your environment, moderate level medical decision making, the mindset really of what that was in the past to what that is now is pretty much consistently the same. So if you have patients that come in that have 2 or more chronic illnesses, diabetes, COPD, hyperlipidemia, heart failure, even if they're stable, but you're doing prescription drug medication management, that's a moderate level medical decision making for that type of patient. So I'm sure you see a lot of those types of individuals in your setting. And then again, high level medical decision making. This is reserved for your really very ill patients, where if you don't intervene and help them today, do something to intervene today, there's a high risk of morbidity or mortality. So, and we are absolutely available to talk to individuals more offline about all the different types of service and how they, what your clinic looks like, what your FQHC looks like, your patient population. This is really important. I want to make sure AMA came out with many new updated definitions to a lot of the terms that before were kind of ambiguous and sometimes left open for interpretation. So what is considered a problem? You may not always have the ability to make a diagnosis during that visit or encounter. So a problem is any complaint, a finding, a symptom, an illness, an injury, a condition, and you can code for signs and symptoms. You're not always going to be able to make a definitive diagnosis, and that is considered a problem. And what is a problem addressed? So just remember the little acronym. We use this when we teach risk adjustment or more value-based type models, but are you monitoring the situation? Are you evaluating it? Are you assessing it? Or are you treating it? Because if I'm a patient and I come to you and I say in the middle of my visit, hey, I have a rash over here, and you say, I'm going to send you off to a specialist for that, and you document that in your note, then that's not a problem that you address today, just because you looked at it and you sent me off to someone else. So again, are you monitoring it? Are you assessing it? Are you treating it? Are you evaluating it? Those are conditions during that visit which are considered problems addressed, and that's really important. Again, there was a whole array of new definitions that came out from the AMA. We're not going to go through all of them, but they do provide clarity on what is an acute uncomplicated injury, what is a chronic illness with severe exacerbation. Again, from an auditing perspective, don't leave anything open for discussion. If you didn't write it, you didn't do it. You know, I think doing away with having to count up the whole history and exam components is going to do, don't copy and paste, don't clone your notes, do away with the unnecessary documentation in the note just to meet the criteria for selecting those levels of service. So again, clinically appropriate history and exam. Make sure you're documenting those assessments and those plans. That is the information in your note that's really going to back up and support the medical decision making for the levels you're billing for and the medical necessity that's going to cover you for those qualifying visits. I just want to talk to you briefly. I know we're running out of time, but the principal care management services, even though they came around under the 2020 updates, they are separately reimbursable. Principal care management is great. It's a lot like the comprehensive care management, except it only requires that the patient have a single high risk disease or one complex condition. We'll look at what those codes mean. They're broken out into two separate codes. The G2064 is 30 minutes, at least 30 minutes accumulated over the month of physician time. And then the G2065 is 30 minutes accumulated over the entire month by clinical staff who's under the direction or supervision, the direct supervision of a provider. These are time-based codes. When you are going to be billing for these services, you have to clearly document the time, and the time has to meet the criteria. Again, so these services now fall under the reimbursement code of G0511. So both the G2064 and 65 fall under that revenue, under that billable code. Here is the actual criteria that has to be met. Again, at least the 30 minutes. Make sure you're documenting the time. Again, it only has to be one chronic condition that's expected to last at least 3 months. And that there is a focused plan for. So this is work that you're doing above and beyond your routine care for the patients. GHA, we have a lot of services available. Again, individual customized training, education on a wide array of services that you're offering. We offer audits for dental coding, behavioral health audits. We can do ICD training and education to make sure that you're getting your highest level of specificity. Also doing evaluation and management services, you know, auditing to help you make sure that your documentation is really supporting the services that you're billing for.
Right, so I'll just add to that right before we sign off that we are working with a number of FQHCs now as part of the QA program to do audits to see from a risk-based basis as to whether or not they can improve their scores or things like that. And we also recognize that the presentation today about how you're going to code, right? I would imagine most of you do not have your clinicians on. So if you want to schedule a separate presentation for them, we are happy to do that. Thank you again for listening and participating, and we look forward to speaking to you soon. Have a good day, everybody.
Have a great day.